Okay, welcome everybody. This is the lab on the skeletal system. We're going to talk about uh, what the skeletal system does, how it's organized. We'll talk about the axial and appendicular skeleton. Then we'll talk a little bit about different types of joints, where bones come together and what purpose that serves. And then we'll talk about how the skeleton develops. So what's shown here is what you need to know and understand in order to prepare properly for the practical. So you need to be able to recognize each of these different bones in the skull. You need to be able to recognize the different vertebral divisions, the cervical, the thoracic, the lumbar. You need to be able to identify the sacrum and the coccyx. And then you need to be able to differentiate between the different ribs. Appendicular skeleton, we're going to address the pelvic and the pectoral girdle, okay, and the bones of the arms and legs. So upper extremity, we're going to talk about the location, function, and appearance of the clavicle, scapula, humerus, the radius and ulna, the carpals, the metacarpals, and the phalanges. Lower extremity, we'll talk about the hip bones, which are called the os coxa, and we'll identify some major features of the hip bone, including the acetabulum, the pubic symphysis, and the sacroiliac joint. And we'll talk about the bones of the lower limbs, including the femur, patella, tibia, fibula, tarsals, the calcaneus, the talus, the metatarsals, and also the phalanges. So with that in mind, what we'll do is we'll start at the top, okay? And at the top we have the skull, okay? Something I'm sure you're very familiar with. The skull is very important because it protects one of your most critical organs, your brain, which sits inside the cavity here known as the cranium. We also have a lot of nerves that run from the brain stem, which basically protrudes inferiorly from the brain through a big hole down here called the foramen magnum. And these cranial nerves run through a lot of different holes in the bones that make up the skull as well. And we'll see a few of those as we get to each individual skull bone. So what you're looking at here is a lateral view, and we can identify some of these major bones. One of the features that we want to be aware of talking about the axial skeleton is the fact that there's only one movable joint in the axial skeleton, and that's the joint between the temporal bone here and the mandible, which is the bone of your lower jaw. All the rest of the joints of the skull are bones that are fused together, and the functional definition of that type of joint is a synarthrosis. So you can see here, this is an example of a synarthrosis. This is called the coronal suture. Okay, this is another example of a synarthrosis. Okay, this is the squamosal suture, and then the lambdoidal suture down here. Okay, we'll get to each of these as we talk a little bit about the joints in the skeletal system. But essentially, what these fused areas of the bone represent are parts of the skull that, when the skeletal system was initially developing, were not fused bones. They had cartilage between them, and so they were actually at that point slightly movable joints called amphiarthroses. You may be familiar with this if you've ever felt the cranium of a newborn and noticed the soft spot in the superior aspect of the cranium, which represents an area where the frontal and parietal bones have yet to fuse. Okay, this is the parietal bone, this is the frontal bone. So by way of identification, let's just go through each of the bones of the cranium, name them, and we'll start on the right hand side of the figure and we'll move to the left, and I'll show you what's visible here. This is the nasal bone. This forms the bridge of your nose. This bone here, your upper jaw, this is the maxilla. This is the zygomatic bone here that forms your cheekbone, zygomatic with a Z. This little bone here is called the lacrimal bone, okay? A little tiny bone that contains the lacrimal duct, which is where your tears drain when you cry. This is the frontal bone, forms the forehead, okay? And then back here, this bone is known as the sphenoid bone. Now, the sphenoid bone is very special because all the other bones of the skull, with the exception of the mandible, articulate with the sphenoid bone, meaning they touch it. Okay, so it has the nickname the keystone of the cranium. This bone here is the temporal bone. Okay, the temporal bone features the um, external acoustic meatus, which is basically the doorway to the ear, and the styloid process and mastoid process, to which bones attached that help us swallow and chew, or muscles attached that help us swallow and chew. This bone here is the parietal bone. Parietal bone. At the back, this bone is the occipital bone. The occipital bone. Okay? So just to review, mandible, maxilla, zygomatic, nasal, lacrimal, sphenoid, frontal, parietal, temporal, occipital. Okay? Notice with the zygomatic bone that you got this little bridge that goes all the way back here to the temporal bone. There's actually a tiny joint that's not really well visualized here in this picture. It happens right about here, and it represents a suture between what we call this projection, which is the zygomatic process of the temporal bone, which reaches out to touch the temporal process of the zygomatic bone. Now you might think, well, what the heck is he talking about? A process. What is a process? A process is just something that sticks out from a bone's surface. Okay? Mastoid process is an example. The styloid process is another example. Okay? So that's the skeleton from a lateral view. The skull from a lateral view. This is the skull looking up from underneath it. Okay, so this would be a view of the inferior aspect of the skull with the mandible removed, and you can see a few other bones from this view that we couldn't see in the lateral view. To review, again, you can see here the maxilla. All right, this is the zygomatic bone here and here, the temporal bones here and here. This funny looking thing here that I'm tracing, this is the sphenoid bone. The sphenoid bone. The sphenoid bone has a very unusual shape. This is also part of the maxilla. These are called the palatine processes of the maxilla, and they form the anterior 2/3 of the roof of your mouth. These bones back here, which we couldn't see in the previous slide, are the palatine bones, and they form the anterior third of the hard palate, the roof of your mouth. This bone down here, which is this, it's sort of shaped like a plate, is called the vomer, and it forms the nasal septum, which is the bone that separates the right half of the nasal cavity from the left half of the nasal cavity. Above the nasal septum, and sort of tucked underneath these bones, right about here where your nose would be, you can't see it, is another unusual bone, which is called the ethmoid bone. Okay, the ethmoid bone forms the anterior surface of the nasal cavity, and it has a long, flat projection called the perpendicular plate that fuses with the vomer to form the rest of the septum. Okay, moving down here, this is the occipital bone. Occipital bone. And you can see just a little tiny bit of parietal bone here and here. Okay? And then, of course, this is the temporal bone. The temporal bone. Okay? Now, a couple of interesting features that we can see right here. This big hole is called the foramen magnum. That's Latin for big hole. And what it does is it serves as the route through which the brainstem attaches to the brain, and also through which the brainstem attaches to the spinal cord. Okay, this big hole right here in the middle. This little bump right here is called the foramen ovale, okay? And we've got a couple of bumps here and here, which are a little tough to see, and those are called the jugular foramina. And what they do is they allow the jugular vein to pass through this hole in the skull and drain blood that's coming back to the heart from the brain. If we look just superior to the jugular foramen, okay, just on top, you got a couple of little holes here, and these are the carotid canals, and these are passageways for the carotid arteries to bring blood up to the brain coming from the heart. As we move forward, we can see the outline here of the vomer. Okay, you can pick up a little bit here. Notice again, looking at the inferior aspect of the skull, that all the bones are attached to each other by these immovable joints, these synarthroses, which are called sutures. Okay, so that's the skull from the underside. Now let's look at the skull face on, and what you're seeing here are a couple of interesting features that we couldn't pick up before. To review, that's the frontal bone forming the forehead, the nasal bone. Behind the nasal bone here and here are the lacrimal bones. This is the maxilla, the zygomatic bone here and here. This is also the sphenoid bone. Okay, notice the sphenoid bone has a very unusual shape. If we were to remove the sphenoid bone from the skull, it would look like a bat with two sets of wings. Back here, the temporal bone, parietal bone up here, okay? And if we look very carefully, we can see the perpendicular plate of the ethmoid bone right here. The ethmoid bone also has two ridges on its lateral surface, which are the superior and middle nasal conchae, okay? You can see them up here. This is the superior, this is the middle nasal concha, and the inferior that's the inferior nasal concha, the middle nasal concha, and the superior nasal concha, which is difficult to see in this view. Now, what the purpose of those is to allow the air that enters the nasal cavity to swirl around inside it and make a lot of contact with the mucous membranes so that it becomes well humidified and warmed up before it gets into the lungs. In addition to that, because the nasal cavity is lined with mucous membrane, it helps trap particulate matter so that we don't inhale that into the lungs and damage them. So that is the skull from the front. Okay, and if we move now to the floor of the cranium, looking from the top down with the skull cap removed, we can see a few other bones and a few other features. This is the top of the ethmoid bone here, okay? The reason the ethmoid bone is so interesting is because it has a couple of features. The crista galli, which is this little ridge right here in the middle of the ethmoid bone, and this projecting flat plate called the cribriform plate. And if you look on your skull, what you'll see is that there's little holes in the cribriform plate, and they're there for a reason. And the reason is that the first cranial nerve, known as the olfactory nerve, sits right on top of that bone, and it sends little projections down, neurons that are capable of detecting odor into the nasal cavity through these little tiny holes. Okay, so that's the purpose of the cribriform plate. Now, the crista galli is important because it's a point of attachment for the meninges, which are the membranes that line the outside of the brain, to attach to at the anterior medial aspect right here. Behind the ethmoid bone is the sphenoid bone. You can see it here, and you can see the major holes of the sphenoid bone, the foramen ovale, the foramen rotundum and spinosum. You can see the spinosum here, that's the ovale, and the rotundum is sort of hidden up under here. It would be about here and here in this sphenoid bone. Now, why do we make a big deal out of these holes? Because they serve as passageways for branches of the trigeminal nerve, which is the fifth cranial nerve that serves muscles in the face. Okay, moving down, okay, we can see here the temporal bone. That's the temporal bone. And then, of course, behind the temporal bone is the occipital bone. That's the foramen magnum, okay? And here you can see the jugular foramina here at the border between the temporal bone and the occipital bone. Remember that that's the passageway through which the jugular vein passes. A couple other features we should talk about while we're here. The sphenoid bone has a little pit in the middle of it called the pituitary fossa, and it is the home of the pituitary gland, which is the endocrine gland that controls the rest of the endocrine system. You can see here the optic canals through which the optic nerve passes. That's the nerve that brings visual information back to the brain. And you can also see up here what we call the greater wing of the sphenoid. Okay, the reason it's called the greater wing is because it's larger than the lesser wing. There's two wings of the sphenoid, a lesser wing and a greater wing, and they both serve as points of articulation for other bones of the skull. Okay, this whole feature here that runs from this ridge to the pituitary fossa to this ridge is called the sella turcica, and that's Latin for Turk's saddle. It's called that because it has a saddle shape to it. Remember that its purpose is to house the pituitary gland. House the pituitary gland. Okay. So, moving on, we can see here a close-up of the lateral view of the skull, and here we can pick up the zygomatic bone, the maxilla, the lacrimal bone, the nasal bone, and then back here, this is a little piece of the ethmoid bone. The sphenoid bone is back here and here, okay? And this is the temporal bone, and this is the frontal bone, and that's a little tiny piece of the parietal bone, okay? So you're just getting a different view of the skull. Here you can see the mandible, okay? The mandible is the only movable bone of the skull, and this process here, which is called the condyloid process of the mandible, is what touches the temporal bone and forms the joint known as the temporomandibular joint, which is what's active when we chew or when we speak. Okay, this is the angle of the mandible right here. Okay, and you've got these arms, which are called the rami. This is the coronoid process of the mandible. Okay, the coronoid process. This is the hyoid bone. Now don't confuse the hyoid bone with the mandible. The hyoid bone lies below the mandible and is the only bone in the body that does not touch any other bone. It's important as a point of attachment for neck and tongue muscles that help us swallow and speak. Okay, you'll see it on your skeleton in the lab about, I would say maybe 3 or 4 inches below the mandible. It's much tinier, although it is shaped similarly. Next thing we want to talk about is the vertebral column. Now the vertebral column is important because it houses the spinal cord. The spinal cord is the highway from the brainstem to the rest of the nervous system. The brainstem in turn is connected to the brain, and this is how we control our skeletal muscle, right? We form a plan of action in the brain, we send that to the brainstem sends that to the spinal cord, and the spinal cord sends that to what we call the peripheral nerves, which head all the way out to a muscle and make it move. Now, you notice again that the spinal cord is housed inside the vertebral column. Again, a wonderful design on the part of the body due to the fact that the spinal cord is vital for our survival. If it's not functioning, we're severely impaired. Um, so the skeletal system, one of its many roles, in addition to providing us the ability to move and a storehouse for a lot of minerals, and also providing a framework to hang the soft tissue on, also protects a lot of our vital organs. Okay, so that's one of the hidden wonderful features of the skeletal system. It also serves as a major site for blood production, and it's the marrow that does this, located primarily in the bones that make up what we call the bony thorax and the pelvic girdle of the axial skeleton. So looking here at the vertebral column, we can see that it's broken into several divisions, and the top division, known as the cervical division, has 7 vertebrae in it, and you can see them up here by the neck, and you'll notice that this part of the vertebral column bends slightly forward. Okay, this is the front of you, and this would be the back of you, and so this is what we call the cervical curvature, and it's bent this way in order to properly support the weight of the head. Down here we have the thoracic curvature. It's made up of 12 thoracic vertebrae, and it articulates to the ribs that form the bony thorax. The ribs touch the vertebral column in the back, and they touch the sternum, the breastbone, in the front, and that forms a nice strong container for your heart and for your lungs. You'll notice in between each of these vertebrae are little discs. These are called intervertebral discs, and they're made up of a special tissue called fibrocartilage, which, remember, is a type of connective tissue. Remember also that bone is a type of connective tissue as well. And remember that one of the major features of connective tissue is that the extracellular matrix that it produces, the stuff outside the cell, is what is most important in its job description. This is what gives connective tissue most of its function. The intervertebral discs form a very special type of joint called an amphiarthrotic joint, which is a joint that is, unlike a suture, slightly movable. Okay, so we've seen 2 different types of joints in our trip through the skeletal system so far. We've seen synarthrotic joints, like the sutures in the skull, that don't move, and we've seen amphiarthrotic joints, such as these articulations between the vertebrae that have cartilage between them that move a slight bit. The reason that the vertebral column moves as much as it can is because it has a lot of these slightly movable joints going all the way from the cervical, thoracic to the lumbar division. Now, you'll also notice that there is a curvature here. Okay, there is a thoracic curvature. The vertebral column bends outward, protruding out the back. Okay, so we have sort of an S shape going on here. And down here we've got the final division. This is the lumbar division of the vertebral column, and it's made up of 5 lumbar vertebrae, and it supports most of the weight of the body. Notice that the vertebrae get bigger the further down the vertebral column you go, and the reason for that is that the further down the vertebral column you go, the more weight you have to support, so the more structurally substantial you have to be, right? It would be silly to have the little vertebrae down at the bottom and the big vertebrae up at the top if you think about the fact that you stand upright on your 2 legs, right? This would cause the vertebral column to collapse. Below the lumbar division is what we call the sacrum, which is 5 vertebrae that have fused together. The sacrum articulates laterally with the bones of the hip that are called the os coxa, and it articulates inferiorly, meaning below it, to the coccyx, which is made up of 4 fused vertebrae. The coccyx is interesting because it used to be your tail when you were inside your mother's womb. At one point during your early development, you had a tail that appeared and disappeared as you progressed from an embryo to a fetus to a newborn. In some people, the tail doesn't disappear, and so they're born with a tiny tail protruding from their sacrum. This is rather unusual. and it can be surgically corrected. But the interesting thing about the fact that you have and lose a tail during your development is that it points out that we probably all were descended from more primitive organisms that still have their tails today, primarily as a way to maintain balance, right? Four-legged creatures use their tails as a way to help them twist and turn when they run around. So an important organ for them, whereas when you stand upright on two legs, the utility of a tail is somewhat minimal. Okay, so other features we want to notice while we're looking at the vertebral column are the spinous processes, which project inferiorly and posteriorly out the back of the vertebral column, and they serve as points of attachments for muscles and ligaments and tendons. And the intervertebral foramina, okay, you can see them here, here, here. Why are those a big deal? Because those serve as exit points for spinal nerves to head out and innervate their targets, okay, whether they be glands or muscles or other structures. So these are the exit points for the nerves that radiate out from the spinal cord. The transverse processes are projecting laterally from the vertebral column and from each vertebra, and again, they serve as points of attachment for ligaments, tendons, and muscles. Okay, now what we want to do next is look at the vertebrae individually, and the idea here is to notice some of the features and figure out what they do. Okay, so what we're looking at here are the vertebrae of the axial skeleton, and we've talked about the fact that they are divided into divisions: the cervical division up near the neck, the thoracic division near the chest, which articulates with the ribs, and the lumbar division here in the lower back, which supports most of the weight of the upper body and lies just above the sacrum. And what you're looking at here are some examples of cervical vertebrae. The first two vertebrae are kind of important. They're called the atlas and the axis, and they get their names as a result of the description of the task that they perform. The atlas is the first cervical vertebrae, and it features these occipital condyles that support the weight of the skull. Okay, these little indentations articulate with the occipital bone, and they are what allow you to nod your head yes. So they form a type of diarthrotic joint. You can see here the posterior aspect of the atlas, the anterior aspect. These are the transverse processes, little holes that are in the transverse processes are known as transverse foramina, and their particular role is to allow nerves and blood vessels that supply the brain and the neck to pass through them on their way up and down from the brain. Below the atlas is the second cervical vertebrae, and that's called the axis. And the axis has a spinous process that projects posteriorly and inferiorly, and a very tiny transverse process. And here you can see the superior articular facet, and what sits on top of this is the atlas. Okay, this is where the two vertebrae come into contact. So this is C2. This is underneath C1, shown over here. And it's a little hard to see in this view, but this projection, called the dens, articulates with the skull and forms a swivel joint, and this is what allows you to shake your head no. Okay, so again, two examples of diarthrotic joints here. The articulation between the atlas and the occipital bone, and the articulation between the dens and the essentially the occipital bone and the foramen magnum. Here are some examples of other cervical vertebrae, showing you a typical cervical vertebrae, and what you can see here are the transverse foramina that are part of the transverse process. That's one of the unique features of the cervical vertebrae, the presence of these two holes here. Okay, the other vertebrae don't have this feature. They have transverse processes, but they don't have holes in them, foramina. And here you can see the spinous process. Notice that in the cervical vertebrae, the spinous process has a fork to it in the back. So that's one of the other ways that you can tell the cervical vertebrae from the other vertebrae. Also notice that they're quite small compared to the thoracic and lumbar vertebrae as well. These are facets on the superior articular process. Ribs attach here. The superior vertebrae touches here. It makes contact with the inferior articular process on the vertebra that lies just above it. And this is the vertebral foramen. Okay, that's the vertebral foramen, so's that. And that is the space through which the spinal cord passes, surrounded by its meninges and anchored into place by a long vertical ligament called the filum terminale. It's at the bottom of the spinal cord, and ligaments that project laterally called the denticulate ligaments. And this keeps the spinal cord from bumping into the bones that surround it and producing damage. And occasionally what can happen is that discs of cartilage that are between each vertebra can sometimes slide out of place if you lift a heavy object in an improper fashion, and this can result in an impingement on the spinal cord that can result in numbness, tingling, and in some cases even paralysis. Here you can see a lateral view of the cervical vertebrae. You can see the spinous process projecting posteriorly and inferiorly. This is the superior articular and inferior articular process. This touches the vertebra above it. This touches the vertebra below it. Here you can see the transverse process with the transverse foramina that allow the passage of nerves and blood vessels to and from the brain. And you can see the division from which the cervical vertebrae come. The cervical division has 7 vertebrae in it. A good way to remember the 3 divisions is breakfast, lunch, and dinner. You always have breakfast at 7 a.m., lunch at noon, and you could think of the lumbar division as the dinner division at 5 p.m. Okay, so think of that as early dinner. Here is a look at the thoracic vertebra. There's 12 of them total. This is a superior view. You can see the vertebral foramina here, the spinous process, the transverse processes, and this is the facet on the superior articular process. This is a facet that makes contact with the rib. The rib has several features. It has a head and a neck and a tubercle, and those are what articulate with these little dimples that are found on the lateral aspect of the transverse process. This is the body of thoracic vertebra. Notice that it is considerably more substantial than the cervical vertebra because it supports more weight. And here you can see the view from lateral. Okay, so you can see here the costal facet for the rib. This is the facet for the rib on the transverse process, and this is the facet on the superior articular process that articulates with the vertebra directly above it. Okay, so the ribs touch here and here, and the vertebra above it touches here, and obviously makes contact with the intervertebral disc that is between the body of each of the vertebra. One of the ways that you can tell the thoracic vertebra from the lumbar vertebra is that if you look at it from the back, this feature here, if you spin it around, and you probably noticed this in lab, I showed you, looks like the face of a giraffe. This whole thing here, this would be the giraffe's nose and his ears, and these would be the giraffe's little antenna, okay? And then when you get down to the lumbar vertebrae, those same set of features looks like the face of a moose. And here you can see an actual thoracic vertebra, and you can pick up here the transverse and spinous processes, the body, and you can also see here the facet on the transverse process for the rib, and the facet on the superior process, which is for the body. And there's the body of the rib right there. And of course, again, the vertebral foramen through which the spinal cord passes. And so here we're looking at the lumbar vertebrae. Notice that they're quite a bit larger and more substantial than either the thoracic or the cervical vertebrae, so we're getting bigger the lower we go. You can see the spinous process is blunt-ended here. It's not quite as spiky as the spinous process in the thoracic vertebrae or in the cervical vertebrae. And you can see the transverse process with the superior articular facets on the superior articular processes, but what you don't see are facets for the ribs, because no ribs articulate with the lumbar vertebrae. There's the vertebral foramina, and here you can see lateral view picking up the body, the superior articular process, the facet on the inferior process, and the spinous process, which, as you'll notice in the lumbar vertebrae, is blunt. And here you can see how the vertebrae fit together. Okay, it's a good idea when you're in lab or in biosis to take a look at the vertebra as they're strung together in the bone box and look at how they fit and be able to tell top from bottom and front from back when you observe these structures in the lab. Okay, now we're looking at the sacrum, which lies just underneath the last lumbar vertebrae and lies just above a bone called the coccyx. And the sacrum is a point of articulation for the hip bones known as the os coxa. They articulate laterally with the sacrum here and here, forming the sacroiliac joint, and they articulate, the sacrum articulates inferiorly with the last lumbar vertebra. It started out as separate fused vertebrae during the development of the skeletal system, but eventually what happened was that the five vertebrae became one single bone, and that's what you're looking at here with the sacrum. You can see here the median sacral crest, which represents what used to be separate spinous processes, which have now fused into a single ridge along, this is the posterior aspect of the sacrum. And you can also pick up the sacral foramina, and this serves as a passageway for nerves that serve the hips and the lower limbs. Now, these little ridges up here that look like wings are called the ala, and that is actually Latin for wing. You can see here the body of the sacrum as well, and you can see the coccyx articulating inferiorly with the sacrum. Okay, it lies just underneath it. You can always tell the front from the back from the sacrum because the back of the sacrum is going to bulge outwards towards you. The front is going to bulge inwards away from you. The back of the sacrum is also rough compared to the front because of the presence of these ridges along the medial and posterior aspect. And here you can see an actual sacrum. This is looking at it from the back. Okay. Now below the sacrum is the coccyx, which used to be your tail back when you were in your mother's uterus, but eventually shrank away to just these four little fused vertebrae that really don't have much of a purpose anymore. We can live perfectly fine without our coccyx, so it's what we call a vestigial organ. Okay, it doesn't serve much purpose now. It used to be important in balance. When we used to run around on all fours back early in evolution, and it also helped us climb trees if it was used as a prehensile tail. But now it's just these little teeny tiny bones down here at the base of the sacrum. Here you can see a look at the bony thorax, and what this diagram is showing you are the different ribs. They can be classified according to their points of attachment. They can also be classified according to the nature of their attachment. So if we look here at the first 7 ribs, these are what we call the vertebrosternal ribs. You can see them here, 1, 2, 3, 4, 5, 6, and 7. And we call those true ribs in addition to vertebrosternal because they have a direct attachment via cartilage to the breastbone, okay, known as the sternum. We also call them vertebrosternal ribs because this indicates the type of attachment that they have. They attach to the vertebrae posteriorly, and they attach to the sternum via a direct cartilage attachment anteriorly, okay, hence the name. Below the vertebrosternal ribs are the vertebrochondral ribs, 8, 9, and 10, also called false ribs. And the reason that we call them vertebrochondral is because they attach to the vertebra posteriorly and they attach to the chondral cartilages anteriorly, which in turn attach to another piece of cartilage that has a single attachment point to the sternum on the lower body of the sternum just above the xiphoid process. And then the last two ribs are called the floating ribs or the vertebral ribs. They're called vertebral ribs because they have no attachment anteriorly, they just attach to the vertebra posteriorly. And they're called floating ribs because they only have one point of attachment. These ribs can be an injury risk. If you get a blow to the lower back, it's easy to dislodge a floating rib where it can puncture an organ. They lie just above the kidneys. They intersect the kidneys about midway. Kidneys are going to be right about here in your lower back. So the kidneys are vulnerable to damage because they don't have the same kind of bony protection that the heart and the lungs do, being entirely inside the bony thorax, the thoracic cage. So you want to be able to recognize these ribs on an articulated skeleton, be able to classify them according to their type of attachment, and also whether or not they're true or false ribs. Okay. By way of clarification, the first 7 ribs are the true ribs, and ribs 8, 9, 10, 11, and 12 are called false ribs, with the 2 last ribs bearing the additional descriptor of being floating ribs. Okay, what you're looking at here is just the sternum and the attachment of the chondral cartilage to it. The sternum lies just in front of the heart and is one of the toughest bones in the body. If you've ever had to cut through a chicken breast, you can appreciate how tough the sternum is. And the sternum has 3 parts. This upper part here is called the manubrium. This is the body, and this is the xiphoid process, which is a major landmark for the process known as CPR, where we try and restart the heart or substitute for the heart by manually causing it to pump blood by pressing on the xiphoid process, which is just above the heart muscle, and allowing the ventricles to squeeze blood out through the body until an EMT comes or somebody restarts the electrical system of the heart using a defibrillator. You can also see the cartilaginous attachments to the ribs here. This is the cartilaginous attachment for the first rib, the second, third, fourth, fifth, the sixth, and the seventh. Okay, there are the cartilaginous attachments for ribs 8, 9, and 10, which attach to a single piece of cartilage which attaches directly to the lower body of the sternum just above the xiphoid process. Okay, this type of joint is a special kind of joint. It's called an amphiarthrotic joint because it permits a slight degree of movement. You can appreciate this when you breathe, right? Your chest cavity expands and contracts as you breathe in and out, and part of that flexibility is provided by these amphiarthrotic joints between the ribs and the sternum. Now, a couple of other points while we're here, looking at the bony thorax as an entire structure, you'll notice that it's excellent for the protection of the heart and the lungs. The heart lies in the middle of the cavity that's bound by the bony thorax called the mediastinum, while the lungs lie here and here in these lateral cavities called the pleura. And so we have an important bony case that protects most of our vital organs, right? The bony thorax protects the heart and the lungs. The cranium protects the brain, and the vertebral column protects the spinal cord. And really the only vulnerable part we have is the area below the muscle of breathing, the diaphragm, which would be right about here, just below the lungs, where our abdominal organs are exposed. And this is probably as much an accident of evolution as anything else, because when we stood up, one of the things that we did was we exposed organs that used to be close to the ground when we ran around on all fours, and so evolution hasn't caught up with us yet to try and figure out a way to protect these soft spots in the human body. Now, we're going to move next into the appendicular skeleton, and what you can see here is features of the pectoral girdle. Okay, this is the clavicle or collarbone, and what you'll see here is that it articulates medially with the manubrium of the sternum. This would be the medial aspect of the clavicle, and it articulates laterally with the scapula, as particular the acromion process of the scapula. Again, to review, a process is simply something that juts out from the smooth surface of a bone. Um, Other features that you can pick up here in the pectoral girdle, the coracoid process, the acromion process of the scapula. This bone here, the upper arm, is called the humerus. This is the proximal head of the humerus right here. And this, of course, is the clavicle and the manubrium of the sternum. Okay, so this is an example right here, the articulation between the head of the humerus and the glenoid fossa of the scapula of something known as the glenohumeral joint or the shoulder joint. So this is one of the most freely movable joints in the body. It's a diarthrosis, and as a result, it's one of the most easily injured. One of the things to note about the different classes of joints is that the more range of motion they have, the more opportunity to be damaged they have. As a result, this translates to the shoulder being one of the most frequently repaired joints in the human body because it doesn't have a lot of bony support, and also because it can undergo such a wide variety of movements. Think about all the ways you can move your upper arm compared to most of the other joints in your body, and you'll appreciate the features of this joint. This is a member of a class of joints also called the ball and socket joint, where this glenoid fossa would be the socket and this proximal head would be the ball. Okay, moving next to the scapular or shoulder blade, what you're looking at here is the back of the scapula. This would be what we call the medial border. Okay, your vertebral column would be right about here, and this is where your bone of your upper arm, your humerus, would be. This is the glenoid fossa. This is the scapular spine right here, and the acromion process. And then up here in the front of the scapula is the coracoid process, so named because it's shaped a little bit like a crow's head. You can also see several indentations in the scapula that are important to note. This indentation right here is called the infraspinous fossa, named that because it's below this ridge, which is called the scapular spine. And this is the supraspinous fossa up here, so named because it lies above the scapular spine. A few other features we want to be aware of are the suprascapular notch, the superior and inferior angle of the scapula, and this, of course, is the lateral border. Now you might ask, okay, well, how can I tell the back of the scapula from the front of the scapula? Well, let's take a look at the back of the scapula and think about it for a minute. This scapular spine is a rough surface, so it wouldn't fit very well against the rib cage. So if you see this projecting out at you, you know this has to be the back of the scapula. You also know that the scapula articulates laterally with the humerus, right? And so this glenoid fossa, this little pocket right here, always has to be on the lateral margin of the scapula. So if you're looking at this view, you know you're looking at the back of a right scapula. Okay, one of the ways that you can tell. On the other hand, if you're looking at the front of the scapula, you see a very smooth surface, and the reason for this is it has to rest directly against the rib cage in order for it to affect its movements, and so you don't have a lot of rough features on this indentation in the front of the scapula. It's called the subscapular fossa, okay? So named because it lies beneath the scapula, beneath the scapula. Here you can see the coracoid and acromion processes, the glenoid cavity, the lateral border, the medial border, and the inferior and superior angles of the scapula. Okay, and again, this is the right pectoral girdle, the right pectoral girdle. Okay, moving on to the bones of the upper extremity, we're looking here at the humerus, which is the big bone of your upper arm. This is the front of the humerus. This is anterior aspect. This is the back of the humerus. This is posterior aspect. And you might ask, okay, how can I tell the front from the back of the humerus? Well, a couple of things, okay? First thing is probably to tell which end is the superior end and which end is the inferior end. Remember that all positions are relative to anatomical position. That's you standing with your feet flat on the floor, your arms at your sides, and your palms facing forward, and your head facing forward. And so this would be the proximal head of the humerus, and this would be the distal head of the humerus. So you can always tell that because the proximal head of the humerus is rounded and smooth. It articulates with the glenoid process of the scapula. And on the distal head of the humerus, you'll notice a couple of little features down here. This little pit is called the trochlear notch. It's so named because it has to accommodate a feature on the ulna called the trochlea, which forms the elbow joint, part of the elbow joint. And then on the back of the humerus, you've got this really deep pit that's called the olecranon fossa, and it has to accommodate a feature on the ulna called the olecranon. So the way to tell the front from the back of the humerus is to look at the distal head and look at the relative depths of these little pits. The deeper pit is always going to be on the back side. Okay, so what you're looking at here is a right humerus, Other features that you can see on the humerus near the proximal head include the greater and lesser tubercle and the intertubercular groove. Okay, the long tendon from the long head of the biceps brachii passes right through this groove and attaches to the pectoral girdle. And you can also see a little roughened area about midway down on the diapasus, the shaft of this long bone, and that's called the deltoid tuberosity. And it's a point of attachment for a muscle called the deltoid muscle, which is a triangular shaped muscle in the upper part of your shoulder. If you're in anatomical position, okay, it would be the muscle that's going to be right laterally to the proximal head of the humerus. It would be right about here, and it would attach right about here. It's a major muscle in what we call arm abduction, basically lifting the arm away from midline. It's also where you get some certain vaccinations. The posterior aspect of the humerus doesn't have tubercles in it, and it doesn't feature the intertubercular groove. So this is a way you can tell, again, front from back and also left from right. Again, a very important thing to remember, left from right, is that the proximal head of the humerus is always going to project towards the midline of the body. So this is always going to project medially. So this is a right humerus, Also, this is a right humerus. This is just showing you some of the other features of the bones of the upper arm. And then over here, we've got the bones of the forearm, the ulna shown here, and the radius shown here. And what's interesting about these is that these bones will roll over the top of each other. When you face anatomical position, okay, with your feet flat on the floor, your arms at your sides, and your wrists, your palms of your hand facing forward, and your head facing forward, if you were to rotate your wrists so that the back of your hand was facing forward instead of the front, that would be what's called the prone position, and that's possible due to the fact that the radius's proximal head, which is down here in this drawing and up here in this drawing, rolls over the ulna, allowing the two bones of the forearm to cross and causing the back of the hand to move to the anterior position. Okay, you can tell the radius from every other bone in the body because its proximal head is exactly the shape of a dime. No other bone has that feature. Now, other important features to notice on the radius in addition to the proximal head, notice that the distal head is fat in the radius. Okay, the distal head is wide and the proximal head is narrow. Okay, and this little bump on the radius called the styloid process, so named because it's sharp and pointy like the stylus of a phonograph needle. It forms the bump on the outer aspect of the wrist when you're in anatomical position. Okay, this is interosseous membrane here. This is what we call a syndesmosis. It's a type of immovable joint formed primarily by connective tissue. And then up here, proximal head of the radius, you can also see in addition to the proximal head, the neck, and this little bump called the radial tuberosity. Okay, radial tuberosity. A lot of bones from the upper arm attach to this point and allow the elbow to move, to flex. The bone next to it is called the ulna, and the proximal head of the ulna looks just like a U. Okay, so this is a good way to remember. U for ulna, proximal head looks like a U. And the proximal head of the ulna forms the elbow joint along with the distal head of the humerus. And so there's three important features in the proximal head of the ulna. The olecranon process, okay, the trochlear notch, and the coronoid process. And so what this little U-shaped proximal head does is this portion of the proximal head, the trochlear notch, fits inside the deep divot on the distal head of the humerus called the olecranon fossa. The trochlea fits right in this little indentation, and the coronoid process actually fits in the indentation that's on the front of the humerus, known as the coronoid fossa. Okay, so this fits into the shallow divot on the front of the humerus. This fits into the deep divot on the back of the distal head of the humerus, and this little indentation, the U-shaped part of the U, is where the trochlea fits. The trochlea is a major feature of the distal head of the humerus down here. Okay, you can see the trochlea here and here. Okay, and this is what allows the elbow joint to flex and extend. Okay, it's another example of a diarthrotic joint. Another feature that's important to know in the ulna near the proximal head is something called the radial notch, and it's a little groove that sits on the lateral part of the proximal head of the ulna, and the proximal head of the radius fits right inside that groove, and that's how you're able to pronate and supinate the forearm. Okay, so next we'll be looking at the bones of the hand. Okay, what you're looking at here are the bones of the hand, and what you can see from this view are the articulations of the radius and the ulna with these tiny little bones here that are called the carpals. Okay, and the articulation of the radius and the ulna with the carpals is an example of a diarthrotic joint. The carpals themselves can slide across each other. Okay, so there's a gliding movement here, and that's another example of a diarthrotic joint as well. You can see here the different carpal bones. Okay, if we start from the thumb, a good way to remember the bone that's right under the thumb in the wrist is the trapezium for the thumb. Under the index finger is the trapezoid, and then we have the capitate right under the middle finger, and then the hamate underneath the ring finger and the little finger. Okay, so trapezium, trapezoid, capitate, hamate for what we would call the distal row of the carpal bones. Now, as we go more proximal towards the body trunk, you can see the scaphoid. Over here is the lunate. This is the triquiertum, and this is the pisiform. And this would be looking at, again, the front of the hand. And the next set of bones we want to address are the metacarpals. Okay, these are the bones of the palm of the hand, and they're numbered 1, 2, 3, 4, and 5. So this will be first metacarpal, second, third, fourth, fifth, and so on. In case you're wondering, on the lab practical, you're not going to get disarticulated bones of the wrist and the hand. You're always going to get a hand fully assembled, but you do want to be able to distinguish the front of the hand from the back of the hand, and the way that you can do that is to look at the pisiform, which is only visible from the anterior aspect. It forms the bump on the medial side of your wrist in anatomical position, the bump that's at the base of the palm of your hand on the lateral aspect. Okay, don't confuse that with the bump of your what you think of as the bump of your wrist, which is actually formed by the distal head, the styloid process of the distal head of the ulna down here. Okay, this is the bump that you might shatter, for instance, if you put your hands out when you fell forward, okay, say on a slippery sidewalk. So again, the metacarpals, the first metacarpal, second, third, fourth, and fifth. Now, these are the phalanges, and in the thumb we only have a proximal and a distal phalange, whereas in the remaining fingers we have a proximal, middle, and a distal phalange. Okay, so again, they're numbered according to the digit. Okay, so the first proximal phalange would be this big bone that forms the base of the thumb. Okay, the second proximal phalange would be this bone that forms the base of the index finger, and so on. Okay, so you can see how they're numbered. These again are diarthrotic joints. They have a joint capsule and synovial fluid, and they're capable of a range of motion. They're a special type of joint that's called a pivot joint, meaning, I'm sorry, not a pivot joint, but a hinge joint, meaning that they can bend in one plane, and you can see them in action if you clench your fist and then release. Clench your fist and then release. This joint is a very special joint. This is a saddle joint, and it's formed by the articulation of the first metacarpal with the carpal bones. And what it allows the thumb to do is a variety of movements. It allows the thumb to circumdict. It allows the thumb to move across the palm and touch the tips of all the other digits in a movement called opposition. And this is the only saddle joint in the entire body, the articulation between the metacarpal of the thumb and the carpal bones here of the wrist. Okay, so just to review, do the carpal bones first, working from the thumb to the little finger, trapezium, trapezoid, capitate, hamate, and then the proximal row, the scaphoid, the lunate, the triquartum, and the pisiform. Okay, again, the front of the hand, Okay, moving down, next set we want to look at, we want to take a peek at the appendicular skeleton. Okay, and one of the things that we want to note here with the appendicular skeleton is the pelvic girdle, and we're looking at the male and the female pelvis, which is made up of several different bones. We can start over here with the male pelvis. You can see the sacrum here articulating laterally with the os coxa. This entire bone that I'm tracing here is the os coxa. Okay, so this is your left hip bone. Now, it articulates in the front in a region that's called the pubic symphysis, this little bit of cartilage right here that joins the bones at the anterior midline is formation of what we call an amphiarthrotic joint, a joint that is slightly movable. Notice in the male that the angle between the front of the os coxa, this is called the pubis, okay, is less than 90 degrees, whereas in the female it's greater than 90 degrees. And the reason for this is so that the child can pass through the birth canal without being damaged. You can see also that the false and true pelvic inlets are much smaller in the male than they are in the female. Okay, considerably wider inlet and false pelvis. Okay, so false pelvis here, true pelvic inlet here, false pelvis here, true pelvic inlet here. This hole in the front is called the obturator foramen. and it serves as a passageway for nerves and blood vessels. And down here you can see the coccyx articulating with the sacrum. This is the sacrum. This is the coccyx. The coccyx articulates inferiorly with the sacrum. The sacrum articulates laterally with the os coxa, and the sacrum articulates superiorly with the lumbar vertebrae. Okay, so just to give you an idea of what we're talking about. Other features we want to take note of while we're here looking at the pelvis, these indentations on either side of the os coxa are called the acetabulum, and they are where the proximal head of the femur articulates, and this forms the hip joint, okay, as we'll see when we move to the next slide. When the child is getting ready to come through the birth canal, there is a hormone called relaxin that causes the cartilage between the bones of the pubic symphysis to become a little bit more distensible, and this allows the pelvis to expand even more widely in order to allow the child's head and body to come through. Moving to a lateral view of the os coxa, what we're looking at here is a right os coxa. This is anterior aspect, this is posterior aspect, and you can see here this is the ilium, this big fan-shaped projection here. This is the acetabulum, okay, which is where the proximal head of the femur sits. This forms a ball and socket joint, a very movable joint, and also a very easily injured joint in the body. This is the pubis, okay, and this back here that you sit on is the ischium, okay. Other features that we want to make note of are the greater and lesser sciatic notch, okay. The greater sciatic notch is shown here, and the lesser sciatic notch is sort of a little bit hidden in this view, okay. It's down a bit. This ridge here is called the posterior superior iliac spine. This is the posterior inferior iliac spine. This is the ala, or the wing of the ilium. This is the iliac crest, this ridge here of tissue. And this is the anterior superior iliac spine, and the anterior inferior iliac spine down here. Okay, spine is just a ridge-like feature on the surface of a bone. And then, of course, the acetabulum. This, of course, is the pubis up front as the obturator foramen right there. And around back you can see the ischium. This is the ischium. This is the ischial ramus. It's one of the arms of the ischium. This is the ischial tuberosity. And then up here you can see the ischial spine, this little tiny projection in the back just underneath the greater sciatic notch. Okay, so you got two of these that come together to form the pelvic girdle. So you'll want to know right from left with these bones, and you'll also want to be able to pick out these features. Okay, moving to the front of the pelvic girdle. Okay, we can see here a medial view. We were looking at a lateral view before. The way we can tell that we're looking at a medial view, we can't see the acetabulum, okay, which is where the proximal head of the femur articulates. But we can see the ilium, we can see the pubis, and back here we can see the ischium. And this is where the sacrum articulates. This is the coxal half of the sacroiliac joint, okay, the joint that exists between the sacrum and the ilium of the os coxa. This is a special kind of joint. It is a gliding joint, and it is an amphiarthrosis. It is a slightly movable joint. You can see here also the features that we were looking at before. You can pick out the ilium, the pubis, the ischium, which is there in the back, the acetabulum, the pubic symphysis, the pubic arch. This is a female pelvis. You can tell because the pubic arch is greater than 90 degrees. And of course you can see the sacrum and the coccyx as well. Okay, moving on, we can see now the femur. This is the big bone of the upper leg, and you're looking here at an anterior view of the femur, and down here you're looking at a posterior view of the femur. And you might say, okay, am I going to have to know left from right with the femur? And the answer is yes. Okay, and so what are some clues to look for to tell that you're looking at the femur from the front versus from the back? Well, number one, okay, the head, the proximal head of the femur, this ball here, is always going to project medially. It's going to articulate with the acetabulum of the os coxa. So this will tell you left from right. This is always going to point medially. This is going to be the lateral part of the bone. Now, how do you tell front from back? Well, there's a couple of giveaways. Number one, the femur generally bows outward towards the front. Okay, so it has a slight convex anterior curvature. Another feature that allows you to tell front from back is the fact that you can't see the much of the lesser trochanter. Okay, the lesser trochanter is this little notch down here. The greater trochanter is this superior notch. Okay, so these are basically processes to which large muscles attach, and this is the intertrochanteric crest. That's only visible from the back of the femur. Okay, so that little ridge between these two projections only visible from the back. But a better giveaway, I think, to tell front from back is to look at the distal head of the femur, and what you'll notice is that you've got a very smooth anterior surface of the distal head of the femur because the patella has to articulate with this region of the bone. That's your kneecap. And you're able to see the lateral and medial condyles, but you can't see this little divot in here, the intercondylar fossa, from the front of the bone. Okay, so that is a really good way, I think, to tell front from back. So to review, greater trochanter, lesser trochanter, lateral condyle, medial condyle, patellar surface, proximal head, distal head. This is the diaphysis, and these ends of the bones are the epiphyses. Okay, that's true for any long bone. Looking from the back, you can see the lateral and medial condyle. You can see the intercondylar fossa. You can see the greater and lesser trochanter and the crest that runs between them. And you're also able to pick up, of course, the proximal head. Okay, so this is a right femur, Okay, let's make sure that we understand where the femur is located. Okay, the femur articulates medially with the os coxa at its proximal end. It articulates distally with the tibia at its distal end. Okay, so tibia is underneath here, and the os coxa is the hip bone, and it's going to be over here. It doesn't articulate with anything laterally. Okay, and with that, I think we should look at now the three bones of the lower limb together in the way that that occur if you were looking at an articulated skeleton. Here you can see the femur, you can see the patella or the kneecap, and then down here you can see the tibia. Okay, this is an anterior view. This is a right femur, a right tibia, and a right patella. Okay, another thing we want to be sure that we understand is the distinction between a ligament and a tendon. Ligaments attach bone to bone, and tendons attach muscle to bone. And we have a couple of tendons here that we want to be aware of. The tendons of the quadriceps muscles attach via the patellar tendon to this little bump down here just under the kneecap that's called the tibial tuberosity. Okay, so what are the quadriceps muscles? The big muscles in the front of your thigh that allow you to extend your knee. Okay, huge quads are usually seen on sprinters and on basketball players, people that use their legs for quick bursts of energy in their chosen profession. Okay, so huge quad muscles here that allow you to extend the knee. The tendon of the four quadriceps muscles, which are the rectus femoris, the vastus medialis, the vastus lateralis, and the vastus intermediate, all attach via the patellar tendon to the tibial tuberosity. The reason this group of muscles is called the quadriceps group, quad means four, so there's four big muscles in the front of the thigh that allow you to extend the knee. The ligament then attaches to the patella and then passes down past the patella and attaches to the tibia at this little bump, the tibial tuberosity. Okay, so this is what allows you to extend your knee. So again, right femur, right patella, right tibia. Okay. Okay. Moving down, we can look at the bones of the lower limbs. Okay, so the easiest way to distinguish these two bones apart is to understand which of these bears weight and which of these is basically a lateral stabilizer. Your tibia, this bone here, is the medial strut of your lower leg, while the fibula is the lateral strut of your lower leg. The fibula bears no body weight. It simply is a lateral stabilizer, while the tibia bears the entire weight of the body and articulates distally with a bone called the talus, okay, and this forms the ankle joint. Other features that we want to note while we're looking at the tibia, the tibial tuberosity here, okay, you can see the medial and lateral condyles which articulate with the distal head of the femur, okay, they form little cup-like depressions that the condyles of the femur will sit in. And then what we have down here, this little point, is called the medial malleolus, this little bump on the inside of the ankle. So a couple of things about the tibia, right? And you probably are wondering, well, I have to tell a right from a left tibia, and the answer is yes. And the giveaways for the tibia are that the tibial tuberosity is always in the front, okay, and that the medial malleolus is always on the medial side of the bone, okay. The tibial tuberosity is also only found at the proximal head of the tibia, so this would be a right tibia, okay. This is the medial side, this is the lateral side, the fibula would be over here, the femur would be up here, and the patella would be right about here. There is an interosseous membrane that connects from the lateral border of the tibia to the medial border of the fibula, and this forms a syndesmotic joint. This is basically an immovable joint. The fibula articulates medially with the tibia articulates laterally with the fibula. And the fibula is one of the tougher bones to figure right from left, but there are some giveaways that will help. The lateral malleolus is found on the distal head of the fibula, and it is a projection that points backwards and downwards. So it projects posteriorly and inferiorly and is found at the distal head of the fibula. The proximal head of the fibula articulates medially with the proximal head of the tibia and has a little divot in here that allows the tibia and the fibula to articulate. So this is what we call the proximal tibiofibular joint. This is the distal tibiofibular joint. And the proximal head has a fundamentally different shape than the distal head of the fibula. It doesn't have this lateral malleolus that projects inferiorly and posteriorly. Instead, it has a little indentation that allows it to articulate with the tibia, which is will be its medial neighbor. Okay, moving down, we're looking here at the bones of the foot, and again, the most important thing here is to be able to tell the top from the bottom of the foot. And how do we do that? Well, we look for a bone called the talus. Okay, the talus has a very smooth, convex surface, and it articulates proximally with the tibia and with the fibula. Very, very smooth surface here. The calcaneus lies right underneath it, and that's your heel bone. It has a very rough surface by comparison. So that tells you top from bottom of the foot. Now, how do you tell left from right? Well, you look for the hallux or big toe, right? You know that the big toe is always going to be on the medial side of the foot, and so that's going to tell you left from right, and the talus will tell you top from bottom. The bones of the ankle are the navicular, the cuboid, the lateral, intermediate, and medial cuneiform bones, and then we've got the metatarsals, which are the bones of the sole of your foot. Okay, and they're numbered just like the bones are numbered in the hand. Okay, the foot is a lot like the hand. This would be digit 1, 2, 3, 4, and 5. So this would be the first metatarsal, second, third, fourth, and fifth. And these are the phalanges, just like they are in the fingers. You can see that the big toe, the hallux, has a proximal and distal phalange, while the other toes have a proximal, middle, and distal phalange. Okay, so you want to make sure and understand the numbering system. The tibia glides over the talus to form the ankle joint, which is another diarthrotic joint. It is capable of anterior and posterior flexion. Okay, you can dorsiflex or dorsextend the foot. The dorsum of the foot is the top of the foot. Or you can plantar flex and plantar extend the foot. The plantar surface of the foot is the bottom of the foot. It's also capable of inversion and eversion. If you've ever sprained your ankle, you've probably inverted your ankle joint and caused the ligaments and tendons in that region to inflame and very, very slow healing because ligaments and tendons have a relatively poor blood supply. And then here what we're looking at are the arches of the foot. Okay, so you can see here the medial longitudinal arch, the lateral longitudinal arch, and the transverse arch. Okay, so from the bottom of the foot it's a little bit clearer. Okay, actually we're looking at the top of the foot here, but you can see where the arches run. This is going to be your medial longitudinal arch, this is your lateral longitudinal arch, and this is your transverse arch. And you can see here the articulation between the tibia, the talus, and the fibula. That we're looking here from the front. Okay, so this would be a lower right leg. Your foot would be down here. Your tibia, your kneecap would be up here, okay, up towards the top of the slide. And the fibula is always going to be on the lateral side. The arches of the foot are a big deal because they make it easier for you to walk long distances effectively. In people that suffer from a condition called pes planus, which is flat feet, sometimes walking long distances can be painful because the ligaments that stretch between these arches can become inflamed, and that can produce a condition known as plantar fasciitis, which is extremely painful. It feels like an ice pick is being driven into your heel every time you take a step. It is exacerbated by conditions such as obesity, which put extra strain on these arches and cause them to flatten out. The way to tell if you have pes planus is if you get out of the swimming pool in your bare feet in the summertime and you can see your whole foot. When your wet feet walk across the dry concrete, you have flat feet. Now, what do you do about flat feet? You can use arch supports in your shoes, and that can relieve some of the strain that is produced in these fascia that stabilize these arches and make walking less painful. Bones can be classified according to their shape. Here you can see some examples of different classifications of bone. A long bone is longer than it is wide or deep. Examples of a long bone include the tibia, the femur, the humerus, the radius, the ulna. Flat bones tend to be relatively flat. They tend to have two layers of compact bone that sandwich a layer of spongy bone between them. Examples of the flat bone include the sternum, the occipital bone, the parietal bone, the frontal bone, and so forth. And then you got irregular bones, such as you see in the vertebra, okay, just an unusually shaped bone that serves a particular purpose. Short bones are things like the tarsals and the carpals, okay, little tiny bones that are approximately cubically shaped, to a first approximation, and they tend to participate in what we call gliding joints, okay. Moving down, we can look here at the structure of a long bone. Long bone is made up of two distal portions, and a distal portion and a proximal portion. This would be the proximal head of the humerus. This would be the distal head of the humerus. These are called epiphyses, okay? The proximal epiphysis and the distal epiphysis. And the shaft that connects the two is called the diaphysis. And the layer of bone that is the first thing you see when you're coming at this bone from the outside is compact bone, and deep to it is a layer of what we call spongy bone, which is arranged in trabeculae, and deep to that is a hollow chamber that is filled in adults with what we call yellow marrow, which is essentially adipose tissue. And this is the medullary cavity. Okay. On the outside of the bone, you've also got a nutritive membrane that surrounds it called the periosteum. And what lives in the periosteum are the bone building cells called the osteoblasts. And the osteoclasts are also formed in this layer of tissue. The osteoclasts are the bone dissolvers, and the osteoblasts are the bone builders. And the cells that get trapped inside the bony matrix are called osteocytes. And once they're trapped, they can't move anymore, so they have to get their nutrients as a result of cytoplasmic extensions between osteocytes that allow them to exchange nutrients and waste products, as well as blood vessels that penetrate the compact bone both horizontally and vertically, which we'll see very, very shortly here. Okay, so you can see here a cutaway of the proximal head of the humerus. You can see here also a couple other important features: the articular cartilages, which are at the distal, the proximal and the distal ends, and they're there to pad and protect the ends of the bones as they participate in the diarthrotic joint. Okay, this would be the shoulder joint up here. This would be the elbow joint down here. And the thing about cartilage, of course, as we talked about in class, is that you're born with all the cartilage you're ever going to have, and the only thing that happens as you get older is that the cartilage wears away, and that's a process known as osteoarthritis. And eventually what happens as the cartilage disappears is that bone hits bone, and when that happens you generate bone spurs, and the bone spurs can lead to solid particles rattling around inside the joint, which causes irritation and inflammation and the pain that's associated with osteoarthritis. The reason this happens is because the cartilage does not grow back once it's been injured. It only wears away, disappears. You're born with all the cartilage you're ever going to have, and all that happens as you get older is it vanishes. The cartilage is actually nourished by the synovial fluid inside the joint cavity, and that keeps the cartilage cells called chondrocytes alive. And as you remember from the first lab that we looked at, if you remember hyaline cartilage has an arrangement of cells very similar to bone in that the chondrocytes are trapped inside the cartilaginous matrix, except they don't get their nutrients as a result of blood supply. They actually get it as a result of the synovial fluid diffusing through the cartilage and nourishing the cells in order for the cartilage to remain healthy. Deep to the articular cartilage, you can see the compact bone here, which is arranged in structural units called osteons, which we'll see more about in a little bit. And then the spongy bone deep to that. And then, of course, down here, we have a very interesting structure called the epiphyseal line, which represents a site where cartilage is found in growing bone, generally in individuals who have not yet exited puberty. And this represents the site of longitudinal bone growth up until puberty ends. When that happens, the epiphyseal plates become these epiphyseal lines, and from that point on, the only possible bone growth is in the widthwise direction as opposed to lengthwise. Okay, moving down, we're looking at the osteon, and we can see here the microscopic structure of compact bone. And what I want you to notice about it is that it's arranged in what we call concentric lamellae that encircle a central canal. Okay, so this is the low magnification view, this is the high magnification view, and this is the actual tissue under the scope, which you should recognize because this was one of the questions on our first lab practical at extreme close-up. What tissue was this? Now, what you're seeing here with these concentric lamellae is that they're studded with these little pits that contain these bone cells, these osteocytes. And the reason that this happens is because as bone is being built, the osteoblasts deposit bony matrix around them and they get trapped inside their own material and can no longer move. So they exist in these little pits that are called lacunae, and they have these little extensions, these cytoplasmic extensions that reach across the lamellae to neighboring cells through canals that are called canaliculi. That's Italian for little canal. Okay, so all these cells are talking to each other throughout the bone all the time. They can't move anymore, and they can't do a lot of bone building or dissolving, but they're still living cells trapped inside their own matrix. Out here you can see the periosteum, and you can see perforating fibers that penetrate the bone, and then you've got the compact bone, and in here you can see the perforating canals. These are the horizontal blood vessels that run through the compact bone, and then you've got the central canals that run up right through the middle of the osteon. The osteon is this whole circular thing, and so compact bone you could think of as looking a little bit like a stack of firewood on its end, okay, where these are the logs. And then the way that the logs are held together is through even bigger lamellae that are called circumferential lamellae, okay, that encircle the entire width of the long bone and hold all these osteons in place. In addition to that, bone also has a lot of protein in it in the form of collagen. And if we were to look at each of these individual lamellae, there's a lamella, there's a lamella, there's a lamella, you would see alternating bands of collagen running through the hardened matrix. And what this does for the bone is it allows it to be tough both against compression force as well as twisting force. So it's built a lot like the way that you would pour a sidewalk or a concrete building, where you have a steel frame and then you pour the concrete around it. The steel frame resists the twisting and the shear force, and the concrete resists the compression. Okay, and it's the same thing with bone. And if you want to demonstrate that to yourself, what you can do is the next time you get a bucket of chicken, shave the wishbone and dunk it in some cider vinegar for about 3 or 4 days. And then when you pull the bone out of the vinegar, all you'll have left is the protein component of bone, the calcium phosphate and calcium carbonate matrix dissolve in the vinegar, and the result will be a bone that is able to snap and stretch just like a rubber band. Okay, so it's kind of a fun little experiment for you to do in your spare time. Here you're just looking at compact bone through the microscope. You can see the central canal. You can see the circumferential lamellae here, here, here. And these little dark pits are the lacunae. And if this were living bone, which this is not, they would have osteocytes in them, okay, holding hands across these lamellae. These are the central canals. They're called circumferential lamellae because they share a center, okay? Circumferential concentric lamellae because they share a center. Circumferential, my mistake, guys. Um, these are the lamellae of the osteon. The circumferential lamellae are the lamellae that surround the entire width of the bone. My mistake. But you can see here how these cells are arranged and how they communicate with each other. Okay, what you're looking at here is just how bone is formed, and bone actually starts out as a cartilage model when you're in your mother's uterus, and what happens is that it's invaded by blood vessels that carry with it bone building cells. And these bone building cells do two things. They destroy the cartilage from the inside out after they build a bony collar around the model, and then they replace that cartilage with osseous tissue, with bone. Okay, so you can see here the blood vessels, the central nourishing vessel invading here, the diapasis of this long bone, hollowing out the cartilage and creating the medullary cavity. And you can see this is what we call the primary ossification center. This is the first place where bone shows up. Okay, primary ossification center. And then what will happen is that this area of bone building will lengthen, okay, head towards the epiphyses from the center. And then at the same time, secondary ossification centers will form in the epiphyses, and bone will be built from the inside out at the distal and proximal heads of the bone. And eventually what will happen when we're all done is that you'll have compact and then spongy bone in the epiphyses. Then you'll have this epiphyseal plate. Okay, this is where new bone growth can happen. And then underneath the epiphyseal plate is going to be the spongy bone, the medullary canal, and this is where longitudinal growth can occur. Okay, so by the time the baby is born, the only cartilage that's left in the bone is the articular cartilage and the epiphyseal cartilage, and that's what allows longitudinal growth to occur up until the end of puberty, and also appositional growth, bone growth in the widthwise direction, can happen throughout life. And the reason that this happens is due to the action of the osteoblasts, which are the bone builders, and the osteoclasts, which are the bone dissolvers, who are constantly remodeling bone as force is applied to it so that it's strongest where the bone is used the most. Okay, which makes sense, right? You want something to be strong at the point where it's going to have to deal with the most force. And so this is sort of an interesting bonus that you get out of regular exercise. When you exercise and apply force to bone, it tends to become denser, and as a result, you put off the thinning of bone that occurs with age much more than it would, much longer than it would normally occur. And this is called osteoporosis, right? The bone thinning that can lead to pathological fractures and massive bone damage. Okay, moving on here, you can see just a little inset here showing you how the growth occurs, right? The cartilage grows near the epiphyseal plate, okay, and also in the region of the articular cartilage. The cartilage is replaced by bone deep to where the cartilage occurs, and the cartilage is actually growing only here in the epiphyseal plate, and the cartilage is being replaced by bone deep to the epiphyseal plate, distal to the proximal head and proximal to the distal head, if you can imagine the two ends of the bone. Remodeling also occurs. The shaft is remodeled by the action of osteoclasts and osteoblasts. You can see here where bone is being resorbed by osteoclast activity and where bone is being added by appositional growth, osteoblast activity, and where bone is being reabsorbed again by osteoclast activity. So what this is doing is just reshaping the bone so that it's better able to deal with the applied force. And this is just a look at how a bone fracture heals. I've got a little video that addresses this that will come shortly after we discuss this slide. Essentially what happens when you fracture the bone is that the damaged ends get eaten away, and then blood vessels invade, and they begin to lay down a fibrocartilage meshwork that connects the two ends of the broken bone after they've been set. And that's something you have to do manually. And then bone building cells come in after that and start to lay down spongy bone, start to lay down first compact bone and then spongy bone deep to that. And then eventually, after several weeks of remodeling, we have a healed break. And you can see here some examples of different fracture types, what they look like, and some comments on them. This is taken out of 5.2 in your textbook, so this is good material to go over. So what I want you guys to do is just stay tuned for a little discussion on different types of fractures and how they heal. Okay, so take a listen. Okay, last thing we want to do before we're done here today is talk about the different types of joints. Joints can be classified according to their degree of movement. A synarthrotic joint is one that does not move. It generally is characterized by two bones coming together, which are connected by fibrous tissue. These are the least easily injured joints because they have the lowest range of motion, which is none. Amphiarthrotic joints are characterized by cartilage that bridges the gap between two bones coming together. There is no joint cavity, there is no synovial fluid, but there is a greater degree of range of motion than you would find in a synarthrotic joint. Examples of amphiarthrotic joints include the intervertebral discs and the pubic symphysis, and the joint that exists between the sternum and the clavicle, as well as the ribs and the sternum, just to name a few. And then the diarthrotic joints are the joints you probably think of most often when you think of joints, and they have the greatest range of motion, and they're, as a result, the most easily injured. Examples of diarthrotic joints include the shoulder joint, the knee joint, the hip, the ankle, the joints between the fingers. Okay, they all have a joint capsule. They all have articular cartilage at the distal end of the proximal bone of the joint and the proximal end of the distal bone of the joint. They're surrounded by a joint capsule filled with synovial fluid that eases movement, and they're generally stabilized by ligaments, which can be either inside the capsule, in which case they're called intercapsular ligaments, or they can be outside the capsule, in which case they're called extracapsular ligaments. And you can see some examples of diarthrotic joints here: the shoulder, the joint here between the humerus and the radius and ulna, and then down here you can see a few other joints, a little bit unusual. The joints between the carpals and the joints between the tibia and the fibula are what we call, this is called a syndesmosis, and this is a relatively immobile joint, and this is an example of a gliding joint here. Okay, so these are the bones here of the wrist. So fibrous joints can either be completely immobile or relatively immobile. This is a syndesmosis. This moves a tiny bit, but not very much. And this is basically connective tissue here. Just to review, knowing what you know about the bones of the lower limb already, this is the medial malleolus, okay? This is the lateral malleolus. So we're looking here at a left tibia and fibula, okay? You can pick that up just from these little anatomical clues that we're already, assuming, of course, we're looking at the front of the bone, which we are, okay? Down here, you can see an example of some amphiarthrotic joints. You can see the cartilage that's between them. In the case of the joint between the first rib and the sternum, we have hyaline cartilage. In the case of the intervertebral discs, we have fibrocartilage, which is on the outside of the intervertebral disc, and then a liquid center called the nucleus pulposus, which is deep inside. And this is the stuff that sort of burps through the intervertebral disc when you have what's called a ruptured disc, which can impinge on the spinal cord and limit movement. Here you can see the pubic symphysis. This is fibrocartilage here in the front, and this is another example of an amphiarthrotic joint, a slightly movable joint. Moving down, we can see an example of a synovial joint, the shoulder joint. And we actually have some excellent video material talking about the various joints in the body, various synovial joints. We have one on the knee, we have one on the hand, and we have another one on the, let's see here, take a look real quick. There we go. And we have one on the shoulder, okay? So this is just showing you a cutaway of the shoulder joint. And what I'd like you to do after you finish watching this presentation is go to the video content area of Angel and open up the Real Player video on the shoulder joint, and it'll tell you all about the various aspects of the shoulder joint, the bursa, the synovial fluid, the labrum, everything about the shoulder joint that you'd need to know outside of what you're already looking at here, which is basically just this is an anterior view, a coronal section through the shoulder joint, showing you some of the major features. Okay, you can see here the acromion of the scapula. Remember that that's that projection at the rear of the scapula that articulates with the clavicle, and it forms a bony support for the superior aspect of the shoulder joint. The coracoid process, which you can't see here, is a bony support for the upper anterior portion of the shoulder joint, but the rest of the shoulder joint is basically soft connective tissue. And this is one of the reasons why the shoulder joint's so easily injured, is because we put a lot of stress on it, especially athletes, and since we have mostly soft tissue surrounding the socket in which the proximal head of the humerus fits, very often we can rip that soft tissue, and that's what we call rotator cuff injury, and that has to be repaired surgically in order for it to heal. Okay, so you can see here synovial fluid, the articular cartilages. You could see the fibrous capsule that contains the synovial fluid. You can pick up the bursa. These are fluid-filled sacs that sit in between bony prominences, and they ease movement, kind of like ball bearings do on roller skate wheels. And then you can see the ligaments and tendons that stabilize the joint as well. This is the tendon, for instance, of the biceps brachii. Here you're looking at some examples of different types of diarthrotic joints, synovial joints, and what you can see here are different types of articulations. If we start up here, this is a ball and socket joint. You see this in the shoulder and the hip, and this is capable of movement in 3 dimensions. A variety of movements are possible with the shoulder and with the hip, more so really than any other joint in the body. Moving down here, this is an example of a hinge joint. This is the articulation between the distal head of the humerus and the proximal heads of the radius and the ulna, and this is a monaxial joint. It's only supposed to bend in one plane. If it bends in another plane, then the joint has probably been injured. Examples include the elbow, the knee, and the ankle, as well as the joints with the fingers and the toes. And then here we have an example of a pivot joint. Okay, a pivot joint is one that can swivel. Okay, you see this between the radial ulnar joint. This is what allows the forearm to pronate and supinate as the proximal head of the radius rotates and allows the radius to cross over the ulna when we're standing in anatomical position and changing from palms facing forward to palms facing backwards. Okay, a movement that we call pronation, but it's also a movement that we would call medial rotation. It also occurs between cervical vertebrae 1 and 2, and this is what allows you to nod your head no. Okay, that's cervical vertebrae 1 and 2. Okay, and remember that that's the joint that occurs between the orodontoid process, the dens of the axis, and also articulates with the first cervical vertebrae, the atlas, as well as with the skull. Moving down, we've got variations on the biaxial theme. Here you can see an example of a ball and socket joint between the metacarpals and the phalanges. Okay, this is where your knuckles would be. You can grip, and you can also wag your index finger, so you've got a little bit more range of motion than you would have in a monaxial joint here. And then, of course, you've got the only saddle joint in the body, which occurs between the carpals and the first metacarpal. And the most important movement here is to be able to take your thumb and to touch the tips of all the fingers on your same hand. And this is called opposition. And this is what enabled mankind to create tools to have writing and art, and really was responsible in no small part for the rise of human civilization. So pretty interesting little joint right there that we owe a lot to. And what you're looking at here are just some developmental aspects of the skeleton, how the dimensions change as we move from embryo to fetus to adult. The dark areas shown in the left-hand panel are what we call ossification centers. The light areas are cartilage. Okay, so you can see that in the fetal skeleton, you've got more separate bones than you have in the adult skeleton, because a lot of the unpaired bones are paired initially, but they fuse prior to the birth of the infant, and as a result, the number of total bones goes down to 206 by the time we have the adult skeleton fully formed. Here you can see the changes in skull related to brain growth here. The cranial vault expands to accommodate a much larger brain. And here you can see how the growth rate of the limbs is greater than the growth rate of the head and the trunk, as you have these relative lengths of long bones changing as we go from neonate to infant to prepubescent to teenager to young adult. And then as we progress, as we age, one of the things that happens as ossification ends and we now enter adult life is that we start to lose bone density. Even in the healthiest of lifestyles, osteoporosis can cause us to lose height. And one of the things that happens as the vertebral column compresses is that we get shorter. As you can see here in this figure of a woman moving from age 40 to age 70, this is the advent of osteoporosis due to the fact that a lot of the weight on the vertebral column is on the anterior aspect. As the vertebrae soften, what happens is that there's a bowing forward in the thoracic region that we call hunchback, and this is typical of osteoporotic individuals as the disease progresses. And again, what can slow the progress of this disease is exercise. Okay, the more exercise you do, the less osteoporosis is going to happen. Okay, this is a type of spinal curvature. Hunchback, also known as kyphosis, okay, thoracic curvature where we are convex posteriorly. Scoliosis is a sideways curvature of the spine and can result in problems with gait and posture. It's found more often in women than in men due to the fact that women often have lower limbs of unequal length. And then we have lordosis, which is an extreme lumbar curvature where the individual thrusts their lower abdomen forward in order to maintain balance. And the conditions that exacerbate this problem include pregnancy and obesity. Okay, it's just a matter of trying to stay upright. And the fix for this obviously is to lose weight or to have the child. Okay, again, make sure to watch the video talking about the shoulder to get a little insight on how that joint operates. And there's also some very good joint videos in the video content area that I'll put up in the announcement section of Angel that I highly recommend you watch in preparation for our next lab practical. And with that, that's really all I have to say today, and I'll see everybody in class.